Hey guys, in this video, we're going to take a look at a case that really tests your ability to connect the oral exam with the medical history. It's one of those that might look subtle on the surface, but if you miss the context, you'll totally miss the diagnosis. So yeah, let's jump right in. All right, we've got a 52-year-old male who comes in complaining, "My lower jaw's been aching and feels kind of swollen." He says it started about 2 or 3 weeks ago. Nothing sharp, just this dull ache on the right side. He also noticed that his face looks slightly fuller on that side, but there's no pain while chewing, no dental pain at all, really. He's had some past medical treatment for prostate cancer, which was managed with surgery and radiation about 3 years ago. He's still on hormonal therapy. So we examine him, and yeah, there's some mild swelling over the right mandible, like just around the body of the mandible. It's firm, not tender. Intraorally, all the teeth look fine. No mobility, no swelling inside the mouth, and they all test vital. There's no sinus tract or signs of infection. We take a pano and it shows this ill-defined radiolucency extending from the distal of tooth 45 back to the angle of the mandible. There's no obvious periosteal reaction, and the cortical borders are kind of fading out. It's not sharply demarcated. All right, so what are we dealing with? Let's go through the options. First up, odontogenic keratocyst, or OKC. Now, OKCs are known for being locally aggressive, and they do often show up in the posterior mandible. But the radiolucency is usually well defined, either unilocular or multilocular, and we'd expect some kind of scalloping or expansion, maybe displacement of teeth. In this case, the lesion isn't well defined, there's no expansion, and the teeth are totally vital. So, yeah, I'd say it doesn't fit. Next is chronic osteomyelitis. So osteomyelitis could definitely show up with some swelling and a radiolucent area, but there are usually signs of infection, pain, fever, pus, or maybe even some sequestra. Plus, we'd probably expect a non-vital tooth or a recent dental infection as a trigger, and this guy has none of that. So this one doesn't really make sense either. Then we've got amyloblastoma, and yeah, that's a good thought. It's a slow-growing, locally invasive tumor that commonly affects the mandible. It often presents in the molar ramus area and can cause expansion and radiolucency. But here's the thing, amyloblastoma is typically well circumscribed, multilocular, and often causes root resorption or buccal lingual expansion. Again, stuff we're not seeing here. So, not a great match. That brings us to metastatic carcinoma. And this is where everything lines up. He has a history of a primary malignancy, and we know prostate cancer, along with breast, lung, and kidney, is one of the most common cancers to metastasize to the jaw, especially the posterior mandible. The ill-defined radiolucency, the lack of odontogenic source, the firm swelling, and the totally vital teeth, that's like textbook. And it's worth pointing out, the mandible, particularly the molar angle region, has rich marrow spaces and slow blood flow, which kind of makes it a prime target for hematogenous spread. So yeah, in this case, the most likely diagnosis is metastatic carcinoma. All right, that's it for this case. Um, I hope this helped you see how sometimes the oral signs are subtle, but the medical history is the key. Always step back and think big picture. Thanks for watching, and I'll see you in the next one.